So welcome to Grand Rounds. It is July 2022. Today we have Lauren Garges talking to us about postpartum running. Ms. Garges is the director of the pelvic floor rehab program at St. Luke's University Health Network and has specialized in pelvic floor dysfunction for the past 18 years. She's board certified in women's health physical therapy and has earned additional certifications in both pelvic floor physical therapy and obstetric physical therapy from the Academy of Pelvic Health. Lauren has presented on numerous pelvic and women's health related topics to both medical providers and local community, and she teaches at St. Luke's School of Nursing on caring for the postpartum population. She's also contributed to articles about urinary incontinence and pelvic pain for Runner's World magazine, and so First for Women's Magazine and Health.com. And she considers it an honor to help her patients achieve improved quality of life surrounding conditions that often go unspoken. As some housekeeping, please make sure you are on mute. Unless you're asking a question, and then please feel free to ask that question. And if you are watching this live, please make sure you scan the QR code and log into EADS so that you get your quiz and your course evaluation so that you can get credit for this. If you are watching the recorded version, you would have already logged on to EADS in order to get this recording, and that is how you also get your quiz and your course evaluation. If you have any questions, please feel free to contact me and I would be happy to help you along. So without further ado, I will turn this over to Lauren Garges.
All right. Hi, everyone. Just going to move forward here. Let's see, Steve, if you can help me a sec. I just forward that way. Gotcha. Okay. So welcome. Thanks for joining. And I'm going to just scroll through the quick slides Steve had me put in right at the beginning. Statement of need or activity description you can read at your leisure. This one is just explaining the purpose of the presentation here. We are going to be speaking about really rehabilitating women in the postpartum period if they're wanting to run, and we're focusing on this really because there are not a lot of guidelines out there, so it's kind of a hot topic in pelvic health world right now, and I think this is something that's important for many of us to understand. Designation statement here that there's 1 hour of CEU credits going to be offered, nothing to disclose. And here are my learning objectives. So we're going to be talking about a variety of issues related to postpartum biomechanical changes. We're going to be talking about psychological well-being, a little bit about the endocrine system, and talk about how to screen your patient to see if they may benefit from a pelvic floor assessment with one of our pelvic health PTs. So talking about running, postpartum running. So in 2020, they did a study about race participants, and actually women take the majority now. We are actually, I think it's at 59% of all race participants in the United States are female. So that's just a slight bit off. But the average age is 37. So the average age is women of childbearing age. And so we want to kind of keep that in mind that, you know, a lot of people are running not just recreationally, but they actually may be participating in some competition as well from a running standpoint. So we will, you know, keep in mind the amount of challenge that could be physically undergoing the musculoskeletal system as someone is training for a race, be it a 5K or even anything up to a marathon. Why is running such a popular thing in this country and really worldwide? Really, it's because it's convenient, it's very cost effective, and really there's a lot of flexibility as far as when it can occur. Really, some studies were done to find out what is the average postpartum time frame that women begin running after they've given birth. And it ranges typically anywhere between 2 to 8 weeks after giving birth. And that is not evidence-based. So these are just the statistics. That is not necessarily what's recommended, though. So we will be talking about what is the best time frame for women to start running. Most of them, frankly, return earlier than they probably should. So 2 to 8 weeks postpartum is kind of the window that most women will return to running if they were a previous runner. But we'll talk about maybe what would be more optimum. So my presentation today is really based on an article that was published in the Journal of Women's Health Physical Therapy through the APTA, and the article was published in the January 2022 issue. And it is called The Whole Systems Consideration of Running Postpartum. So you know, we're talking about 10 different things that we want to consider with our population, and I was just going to say with our female population, but I want to be correct in saying that as I'm referencing this, I'm really in particular speaking about anyone who has a uterus. So I mean no disrespect if I use the word female or she, if you know we happen to be speaking about someone who's gone through some changes in that way. So really, we're talking about anyone who has a uterus and who is given birth and who wants to return to running. So I'm not going to go over all 10. I think I'm going to go over 7 of them today that I think are particularly important to be talking about. So why should we use a whole systems approach? Why do we want to kind of consider all these different, you know, areas of rehabilitation of the postpartum patient? Well, really, we need to go beyond just musculoskeletal considerations because the recovery time for tissue in the postpartum time is averaging between 4 to 6 months based on 2 studies that were done in 2010 and 2015. And that's well beyond the traditional 6-week postnatal check that's typically done once a woman has her baby and goes back to her OB. And at that 6-week time frame, at least in the United States, most women are cleared for all activity. But recognizing that it can take 4 to 6 months for tissues to heal, we, as physical therapists, are really in a good position to be assessing when is appropriate for each individual patient to return to running. And so what we want to do then is do a risk-benefit analysis to figure out with each patient that's in front of us when is appropriate for them to be running, and that's kind of what we're going to go over today. It is very individual for each person, so there's not like, you know, a written in stone kind of, you know, paradigm that we follow. We really want to make it very individualized, so we'll talk about that. So let's talk first about physical deconditioning. And certainly this kind of makes sense if we have a patient in front of us who birthed a baby, whether it's a vaginal delivery or a cesarean delivery. We want to think about, you know, 3 different things that could possibly be part of our assessment. So first of all, you want to think about their physical condition as they present in front of you. A woman who's wishing to run, wishing to get back to running, if I'm assuming that she's been a runner, I'm sorry, I should say this. I'm assuming that she's been a runner before her pregnancy and is wishing to return to running again, because there's a lot of factors that go into her incentive to run, her goal setting, her mindset. Many of us have worked with runners or are runners and know that there can be, you know, a little bit of a goal setting personality there. So we want to kind of keep that in mind. But when we're thinking about their physical condition, we want to consider their cardiovascular fitness. We want to consider their muscle mass, their strength, and their endurance. So these are all very common things that you want to be assessing when you first see a patient in front of you. And those 4 areas are typically in recovery mode during those first 12 weeks postpartum, which is called the 4th trimester. So we want to kind of make sure we're reviewing that. There are biomechanical changes, certainly, that we will see in women when they start running again. And the pelvic floor, the trunk, the hip, and the foot are really the main areas that can be kind of a challenge from a recovery standpoint. There was actually a study in 2019 which revealed that women in the fourth trimester tend to reduce their pelvic and their trunk motion. So they actually have less hip extension and they have a more rigid trunk to kind of actually compensate for the laxity that may be existing in that postpartum period, particularly if they're breastfeeding. So we'll be talking a little bit more about breastfeeding considerations, and I'll reference that study a little further, but it can be protective initially, but may and later lead to some compensatory patterns that we want to consider. And then again, we also need to consider their birth experience itself from a deconditioning standpoint. The length of the actual pushing phase, surgical, considerations that may have happened, whether instruments were used like a vacuum or forceps, the types of anesthesia that the woman may have had, and then if she has any sutures, can all affect her physical condition. So these are questions that we need to ask and recognize. All of those things I just spoke about can actually delay tissue healing. So if it's a female who pushed for, if it's a patient who's pushed for 6 hours and she had a vacuum extraction, and then she has 15 stitches, her readiness for running is likely going to be delayed or certainly impaired. So these are all things we want to keep in mind. Now, how does physical conditioning affect physical therapy specifically? What we want to do is keep our PT hats on and recognize the strength and the conditioning demands, the load impact of running, and then also address any musculoskeletal deficits, and then consider those other things that I just spoke about. And we may then want to encourage a more gradual return to that impact, slowly increase the intensity, and really guide those patients through, returning to running. It may actually be best to start with a run-walk interval, which in our office, when we are working with patients, that is actually the protocol that we typically use with our postpartum runners. And it's usually a 2-to-1 walk-to-run ratio. And I'm actually going to speak about that a little bit later with the musculoskeletal check at the end here. So let's talk about the next one. We're going to be talking about sleeping, and more than anything, sleep deprivation. Any of us who have children certainly, unfortunately, are well aware of how impactful this is on just every aspect of your life. We kind of joke about it. There's all these memes out there about, new parents and lack of sleep, and, haha, it's really funny, but really it actually has a lot of implications to recovery and really to the overall health of our patients. Studies recommend 7 to 9 hours, and I have never met a new parent who has gotten that. Really 90% of new mothers per research are getting less than 7 hours a night. The average is about 3 to 4 hours of sleep. So we're cutting the goal in half. And I actually found a really interesting study as I was preparing for this that said it can take 6 years to recover from the health effects of sleep deprivation after having one baby. So if you have multiples, I'm not sure how many more years it takes from there. I have an 18-year-old and I do not know if I've recovered yet. So I will say that. So sleep deprivation is huge. And this is not something that you can really prepare for. We can talk about it. We can, warn patients and people that this is going to be tough, but really there's nothing that prepares you. So, but there are certainly health effects we need to consider. Cortisol levels increase. So if we're not getting enough sleep, it affects endocrine system. Your cortisol goes up, and then therefore your stress response is higher. So, people are just not able to tolerate the multitudes of stress that they have with a new baby in front of them. So, that's certainly, we want to kind of keep this in mind. Really, lack of sleep contributes to elevated glucose. So we need to be recognizing if there's someone who potentially had gestational diabetes, The doctors say GD ends when you're no longer pregnant, but in the fourth trimester, they may want to have their blood sugars monitored and recognize that their metabolism may be a little bit impacted in that first 12 weeks. Immune health is affected with sleep deprivation. And then I got this from an article, not necessarily referencing postpartum sleep deprivation, but these are just overall health effects that we notice. So really the thought is that when we sleep, our breathing slows down, our muscle activity slows down to free up energy to help the immune system do its tasks. And if we are not getting enough sleep, that energy is not available to really help with immune, homeostasis and things like that. So it can affect your immune system very strongly. All of us who have been sleep deprived for one reason or another certainly know that cognition is affected. Brain fog, mom brain, all those things is very true when we're not getting enough sleep. And it actually can have an effect on the gut-brain axis. So it can affect your psychological health, your GI system, and there is a very definite connection between sleep deprivation and postpartum depression. Most of the research articles that I was coming across as I was preparing for today reference postpartum depression and lack of sleep. So there's a huge connection with that. The musculoskeletal effects that we might see because of sleep deprivation really reference just the fact that you're going to have delayed postpartum tissue healing. So the risk of injury with running increases when we don't have enough sleep based on just the things that you're seeing here. So, really skeletal muscle is a regulator of your metabolism. And so if that's, if our protein synthesis is impaired or delayed in any way, it affects so many other things. So recognize that tissue healing is slowed. What can we do or what can we recommend for our patients? These are, easy to say, sometimes hard to implement, but we would recommend getting rid of the screens and trying to, turn off the phone if you can when you're trying to sleep. Sleep masks would be very helpful. Earplugs are probably not very practical. And frankly, I meant to take that out of this presentation because you need to be able to hear your baby monitor to hear if you need to get up for the babe. But a cool room is helpful. The baby often is in the room with mom or, sleeping next to the bed. So make sure you keep your babe wrapped up in at least 2 extra layers, but a cool room helps with sleep and avoiding caffeine and alcohol. If someone's really suffering, it may be worthwhile to consider a sleep consultant to help figure out some sleeping patterns with the baby, or even an overnight doula who can give them a little bit of a break and could take the baby when the baby awakens so that at least they can get a little bit of rest there. And of course, shifts between parents can be very helpful. And how does this affect physical therapy? So really with this, we do need to talk to our runners about prioritizing sleep and whether it can actually be counterproductive if they're so exhausted and they're trying to get some miles under their belt. It actually can have a negative effect on them. So some just really compassionate talks with our patients about, let's look at the risk-benefit analysis here and make sure that you're not hurting yourself in the long run is really an important conversation to have. Next thing we want to talk about is breastfeeding. And about 50% of the population in the US is breastfeeding, still at about 6 to 8 weeks postpartum, when this is when most women are returning to running, whether they should be or not, which I'll talk about in a short bit, but it is about when most women are starting to hit the pavement again. So about 50% of those patients are breastfeeding, and certainly breastfeeding has many benefits to mom and baby, and exercise has benefits to the mom. So, we want to encourage our patients to breastfeed, and they certainly can do so with running. It has been shown to decrease postpartum depression, and certainly breastfeeding helps with bonding with the baby. So we will absolutely encourage that. But there is a misconception out there, I think, that if a female is breastfeeding, that she's potentially at a higher injury risk because of hormonal influences. I have heard that when a woman is breastfeeding, that she is inherently much more lax in her ligaments and in her joints. Some of the decreased estrogen effects can, make her muscle mass, kind of less, and that she's going to have foot issues. There's all kinds of misconceptions out there, and I'd say it's actually very individualized. So this is where your assessment skills really need to come into play. What we do find is that women often do have a little bit more genu valgus. They do have a little bit more of an anterior pelvic tilt. They have increased thoracic kyphosis. So these are things that we should be seeing and looking for, but that doesn't necessarily increase the risk of injury, especially if we can rehabilitate them correctly. But here again, we do see that sometimes they'll protect themselves. So early on in the first typically 6 months of the study that was shown in 2019, women will have less hip extension and they have less overall pelvic movement to kind of compensate for any increased laxity that they may have while they're breastfeeding. And again, this is protective, and I do think it's a good thing. But if those changes persist in the long term, I do think we're likely going to see maybe some harmful effects. So that's something we want to keep in mind. There is something called the Beighton hypermobility scale, and this is something we use often in our office to assess if a woman who is breastfeeding and running does have some extra flexibility in her joints. So the scale is 5 movements, and the score of 6 or more is suggestive that she is hypermobile, and she may even want to be talking to her doctor about whether she has Ehlers-Danlos syndrome or EDS. So the 5 tests are the pinky test. You want to see if you can get to 90 degrees. With your pinky up in the air, which I can do on both sides. So that I would score 2 points so far. You also then want to see if the thumbs can touch the forearm. Hopefully you can see here. That I cannot do, but that would be 1 point on each side if you can. You want to have the elbow straight. They should have a 10-degree Recker bottom in both knees and 10-degree hyperextension in the elbow, on both elbows, and then if they can palm the floor with flat hands and no knee flexion, then that's also a point. So we see patients with hyperflexibility quite often. So clearly with running, we want to then be watching on the impact on the hips, knees, and feet and spine, really, with this amount of hypermobility. So the Beighton scale can be very helpful. There is also some blood work that can be done to assess for EDS. So their PCP maybe who's going to be looking into that for them. And there's a lot of energy demand. This was actually new to me as well. As I was preparing for today, I discovered that a woman who's breastfeeding actually burns 500 calories a day just in breastfeeding. So there is a lot of energy that goes into making breast milk and, and then kind of feeding that to her baby. So that would equate about 4 miles of running a day if we think about the caloric burn. So it's kind of interesting. So they both are quite energy demanding, both running and breastfeeding. So if you have a patient who's doing both, we need to counsel them adequately, make sure they're getting enough calories, and talk about that kind of thing. Like if you are doing both, your energy demands are quite high. So they need enough calories, they need enough fluids, and they need to make sure they are resting enough, as we had spoken about. Some interesting things related to breastfeeding: vigorous exercise, such as running, does not change a female's or patient's milk volume. The composition is not affected, and the studies show that infants are accepting of milk from, runners and non-runners alike. So we can certainly encourage our patients to continue breastfeeding while running. We do recommend that a patient would wait 1 hour after her run before she either pumps or feeds her baby, because the milk does tend to be a little bit more acidic. So that might upset baby's tummy, or they might reject it. So after a run, you want to wait 1 hour. So certainly timing is of essence with that. But breastfeeding is certainly, we want to make sure we're encouraging our patients. The next thing I want to talk about is what I call RED syndrome. I'm not sure if I'm pronouncing that correctly, but really it's the relative energy deficit in sport, which was formerly known as the female athlete triad syndrome. So what is that? And does this occur in our postpartum patients? So, well, it certainly can. And what it is this an energy deficit relative to what's taken in versus what's being expended. So putting that in other terms, we find that this is really common in women that are not taking in enough calories, and they're burning more than they are intaking. The effect on the body with this is that they'll typically have some decreased bone growth. They will lose their periods, and they're prone to fractures. So we will see this in athletes who are nulliparous, who've never had children, but we can also see this in the postpartum patient. And I think it's hard to catch because if we look at these key syndromes, the symptoms are loss of period, which is amenorrhea, sleep disturbance, pelvic floor dysfunction, and a depressed mood. All four of those things are very common in postpartum patients to begin with. The only one that is not as common would be a stress fracture. So, it's pretty easy for these people to kind of slip by and for us not to catch this. So we need to be kind of keen in paying attention to these symptoms. But how would this affect our physical therapy? Well, really what we need to recognize is this is a major lifestyle change for our patients. Having a new baby to care for as they're physically recovering is a lot for many people to kind of go through. Number one, they have a lack of routine. Anyone, again, who's had a newborn knows that the newborn drives the show and there is no routine. So that can be quite upsetting for people who in particular are runners, who are very much creatures of habit, who are very goal driven. This can be really kind of throwing their life into a tizzy. So we need to kind of talk to them about maybe giving themselves a little bit of grace and recognizing that this is not forever, but this lack of routine can be quite a challenge for them. Number two, eating habits in many new parents are also very altered. And again, as we had just spoken about the energy demands that go into running, we need to make sure that, we can talk about what are you eating, when are you eating, and is that enough intake to kind of keep up with the demands that your body needs right now. We've already talked about sleep deprivation and how that can have such a negative effect, and there's not any new parent out there that's not going through that. And then, of course, runners are known to put some personal pressure on themselves, and they're going to be wanting to get back to their sport. So this, we need to be a little gentle with this conversation and really kind of talk about pros versus cons and keep our eye out for signs that maybe we want to pull back a little bit and hopefully help them, guide them through doing so. The next thing I wanted to go over was a little bit about fatigue, but really about an interesting thing that can happen with the endocrine system, which is a postpartum thyroiditis. And so when we are pregnant, what happens with the immune system, it actually really goes through a lot of transient phases. So in the first trimester, those first 13 weeks of pregnancy, a person's immune system is in fact suppressed. And the reason for that is that we don't want to be rejecting that new embryo. So we want that little guy to smuggle into the uterus and not have our body reject it as a foreign body. So that is when women are most vulnerable from an immune standpoint. Everything's kind of suppressed, and that's why it's important for them to, kind of get vaccines and again, avoid the flu and things like that. As the pregnancy progresses, the immune system slowly ramps up again, and its protective, effects are full on by the time the baby is born. But this transient immune response that occurs during pregnancy kind of throws the endocrine system off a little bit, so that once a woman is now in her postpartum period, in that first year, and things kind of stabilize, her pituitary gland and her thyroid are kind of in a little bit of like kind of restorative mode. And unfortunately, the thyroid can go a little wonky. So this is when we will very likely see some hypothyroid syndrome. And the I feel like I've said this repeatedly, this also mimics postpartum depression. Symptoms that we can see: irritability, fatigue, but also they may describe heart palpitations and some, unique aches and pains that don't tend to necessarily fit the mold. So we want to keep your eye out for that. That might be suggestive that she wants to see her PCP or even see an endocrinologist. She may have difficulty losing weight, which many of us associate with hypothyroidism, and they, even can have trouble with milk letdown. So their milk ducts may not be functioning at optimum, and she may be having some trouble breastfeeding. So all of these could be some symptoms of this thyroiditis. And this is an important kind of differential diagnosis consideration that we want to keep in mind. You might see someone with a mom brain or really excessive fatigue, and keep this one in mind, because this is something that we, I think, overlook, and potentially in this patient population. Psychological well-being is another one that is a biggie, and about 50% of women do not have diagnosed mental health disorders in the postpartum period. And so, 50% are not even being treated or being recognized. Thankfully, here at St. Luke's, we have the Baby and Me Center, which is located on 8th Avenue in Bethlehem, and that actually is where we have some fantastic counselors for anyone who is experiencing some postpartum depression or some mental health concerns related to this. So that's where I send many of our patients who we think could use a little extra help. But we also use the Edinburgh postpartum depression scale, which is a questionnaire that questions your mental well-being over the past week. And if you score 10 or more points out of 30, that's when we think, okay, you probably could use a little help here. We will often call the OB and talk to the patient about it and see if we can get them a little extra help. But related to psychological well-being, we want to think a little bit about both the physical trauma that that patient has been through and the psychological trauma potentially that she may have been through. Certainly when we talk about physical issues, we're talking about tissue injury, pain that she may have, and bowel or bladder dysfunction. And from a psychological standpoint, this is considered a form of PTSD. The patient may have some trauma memory with her delivery experience, and this can affect, obviously so many things. One thing I do want to touch on too is really the fact that when a woman is in labor and in the labor and delivery area of the hospital, informed consent is actually essential. And this is something that I counsel a lot of patients on when they are pregnant. There's a lot of invasive things that may potentially be going on, and informed consent is important. So medical providers should be asking patients for permission to be doing cervical checks, to kind of examine parts of their body, and that helps to protect against these kind of traumatic experiences. So I feel that women should be empowered to know that informed consent is important, and informed consent is not just a nice thing to do, but it's actually required. So you can talk to your patients when they're pregnant, talk to your friends and family. When you're giving birth, they should ask permission before they're checking you for whatever. So I just wanted to throw that out there. But how does this affect physical therapy? Really, we need to use our clinical judgment. I think many PTs are really pretty intuitive when recognizing when something is off. when your patient in front of you is not presenting in a way that feels safe to them, or kind of from a mental health standpoint, that something is not doing very well, and we need to then refer to appropriate support services. Sometimes, unfortunately, when we're referencing running can be an unhealthy coping strategy. So if you do have a patient who is running and you're getting that vibe, or you just have that feeling, it's absolutely worth a conversation. And finally, musculoskeletal considerations, which is really our bread and butter. What I'm going to do is go over here this kind of little diagram as far as, if you have a patient in front of you and she wants to return to running, she doesn't know if she's ready, how do we as PTs kind of go through this? So we'll start here, and we're looking at, first thing, is she at least 3 months postpartum? So I've talked about when is appropriate, when should she be returning. Most women return 2 to 8 weeks after, and as a PT, I would say I think that's a bit early. Again, it is individual, but the latest studies and the latest guidelines are at least 3 months, which, in all honesty, most of our patients do not want to hear. That feels very long for them, but that is the latest recommendation. So if they are at 3 months, yep, you can continue screening. If they're not, it's individual. So I will still kind of talk to them about it, depending on how they're looking. I'll still say, okay, let's assess you. Let's see if you're ready to go back. So the objective screening, what should you do? Well, I'm a pelvic PT, so I'm going to recommend that they probably should have a pelvic floor assessment done before they run. That is not, going to be an option for every single office. We have 11 offices right now that have pelvic floor physical therapy available among our outpatient sites. So you may want to send your patient who wants to run to a pelvic floor therapist just to clear the pelvic floor. My next screen will go over how to know if you need to send them to pelvic PT. So we'll talk about that in a moment. Of course, we're going to use our musculoskeletal hats here and do our strength testing and looking at kind of just biomechanics. The latest research recommends that a BMI of less than 30 is optimal from a pelvic floor standpoint. If they have a BMI of above 30, there is a much higher likelihood of pelvic organ prolapse. I'm not always a lover of BMI, but that is something that I do keep in mind when we're talking about running because of the load impact that happens there. We want to screen the abdominal area. Certainly want to check the abdominal strength, abdominal tone, and screen for diastasis rectus. You can do a video analysis or a load impact screen. Again, that's not available at every office, but certainly we can do biomechanical assessment of kind of what running form looks like. Consider, again, Rett syndrome, if the patient presents with some of those signs or symptoms, and of course talk about breastfeeding, sleeping, all those kinds of things that I've already gone over. If the screening is passed and they you can check all these boxes, I would say you can then introduce to them a graded return to running program. In our office, when they've passed all these tests, we typically start with running 2 days a week. They run, it's a run-walk program. They walk for 2 minutes and run for a minute, and we kind of decide what their best pace would be, kind of based on what their goals are. So that's generally how we reintroduce it. And we actually have a 7-week return to running kind of protocol that we follow for most of our patients. I'm happy to share that with anyone. If anyone would like to know what our protocol is, please reach out to me. I didn't include that in today just for time's sake, but we can certainly share that with anyone. And I want to just keep on moving here. So we'll go, this is the screening tool that I discussed. And this is not just for your running population, but really for any patient to see if you think they might benefit from a pelvic floor assessment. It's called the Cosian Pelvic Dysfunction Screening Protocol. And these questions, if 3 or more of them are positive, it is suggestive that they may very well have some pelvic floor dysfunction. So they are bowel, bladder, and pain questions specifically in the pelvic area. So this is a great way for you to know if you want to refer to one of your pelvic floor colleagues with any patient who's in front of you. And These are some tests that we do when we have a patient in front of us to see if she has good posterior chain control, if she's got good, single leg balance, really strength tests. So these are 5 of the exercises that we do in our office before they return to running. In fact, after these 5, we then also introduce load impact. So we do jumping, bounding, running in place. And when we do all of that, we're assessing them for any pelvic pressure, like would indicate potentially a prolapse. So if they feel like heaviness or pressure in the vaginal area, we stop. We say, okay, let's check that. Or if there's any incontinence that goes on, we'll stop. But these are the tests that we have them do. They have to do 20 of each. If they cannot do, for example, 20 single leg sit to stands in a chair, that then becomes their homework. And they will be working on that until they can complete that. And they will not return to running until they can do 20 single leg sit to stands, as an example. And that's everyone's least favorite exercise. That one's actually quite challenging. If you've never done that yourself, you should. 2 cases I want to go over real quickly. Case number 1. 28-year-old. She's had a baby 10 weeks ago, vaginal delivery. It was uncomplicated. Her daughter is 7 pounds, 4 ounces. She has seen her OBGYN. She was cleared for all activity, and she's a little tired. At 10 weeks, she will be. She's breastfeeding every 3 hours, hence her fatigue. But she's not complaining of any type of pelvic floor dysfunction, be it bowel issues, incontinence, any vaginal pressure, anything like that. Her BMI is normal, but she has 15 pounds from the pregnancy that she would like to lose. She's expressed that running for her helps her mental well-being. She has a neighbor that she likes to run with, and sometimes she will, of course, run by herself. But she's heard conflicting recommendations. Should I run or shouldn't I at this point? How do I get back to running? So what would be the risk benefit analysis with this particular patient? So anything in green is a potential benefit. Anything in red was something we want to kind of recognize may be a risk. Fear of movement. This is actually something that some of our postpartum patients do have. She does not necessarily present with anything that is suggestive of that, so we're okay there. Improved psychological well-being and social interaction, absolutely. This would be a great way for her to have some time to herself or time with her neighbor. And this is such a transitional life phase for her that this probably would be very healing for her. Physical deconditioning. She wants to lose 15 pounds. And she doesn't seem to have any pelvic floor dysfunction right now. We would have to do a screen and kind of check her strength and look at a lot of the other musculoskeletal issues to make sure she's okay with that. But overall, that seems to be okay. And she is a little tired, but within reason, a bit of aerobic activity can actually promote better sleep for her. So I think that would be a potential benefit. One of the negatives, we talked about that 3-month time frame, and she's only at 10 weeks right now. So that might be a risk that she's a little bit early on this postpartum time scale. But it's only 2 weeks away till she'll be at that 12-week point. So I would say that's probably going to be okay. And of course, yes, sleep loss is a challenge with all of these patients. So what I would say is the risk to benefit analysis, I would likely introduce running with her, and I would probably have her do a guided return to running and gauge how she feels as she's doing it. But there's no glaring red flags that would necessarily prevent this patient from starting running. Case number 2, though, here we have our 32-year-old. She had a VBAC, which is a vaginal birth after cesarean. So yay, good for her, because a lot of women don't want to have a vaginal birth after cesarean. So, but she wanted to have that experience. So she has 2 children. She has a 3-year-old, and then she has her 8-week-old baby girl. It was pretty big, 9 pounds, 8 ounces. She's not breastfeeding. She's being bottle fed. She did have had some tearing with delivery, and they needed to use forceps because the baby was a little bit larger. She is running right now. So she's 8 weeks postpartum, and her OBGYN did clear her for all activity when she went for her 6-week and check. So she was happy. Her doctor said, okay, you can do whatever you want. So she did. She started running 2 miles, approximately 3 days a week. And when she runs, she has a little bit of urinary leakage, and she feels some like pressure in the vaginal area. She is concerned that because she's gained 35 pounds, or I'm sorry, she has 35 pounds that she would like to lose. I'm not sure how much she gained during her actual pregnancy, but at 8 weeks, she still wants to lose 35 more pounds. Her BMI is 34. She's having some calf pain when she runs. And she did have some postpartum depression after her first baby. She's very tired, and she does feel heart palpitations when she is running. And she's just kind of sad. Like, she's worried about her inability to really bounce back, her weight gain. And she can, only really do running. That's all she can afford. When her husband comes home, she gets a little time to herself to go out to do this activity. But she is a little bit worried about what she's feeling in her pelvic area. So risk-benefit analysis with this patient. Certainly weight management. We know that aerobic activity, again, can help her. So that is a goal of hers. And, that is something that we could potentially say would be in the positive category. Improved psychological well-being, for sure. Exercise can help with that. And given that she does have a history of postpartum depression and she's feeling a little bit inadequate as a mother, I would actually put that in the positive category of potential benefit. But I would have a few medical concerns with this patient. Thyroiditis is what comes to mind when she's talking about heart palpitations, her aches in her muscles, and her extreme fatigue. So this one I would be referring to her OB or even endocrinology, given what she's describing. Musculoskeletal wise, pelvic floor dysfunction absolutely sounds like that might be going on because she's having some urinary incontinence and pressure in the vaginal area. So she does need to have her pelvic floor assessed. Also, the time scale. She is only at 8 weeks. Her doctor cleared her at 6. So here's where, we need to recognize that there's not much evidence to support return to exercise at 6 weeks postpartum. Actually, there is 0 evidence to support return to exercise at 6 weeks. And that is what our patients in general are being told. So we can talk to them about that and talked about why we're seeing various things that might have them potentially pull back a little bit and kind of heal before they do return to some of those activities. And finally, her BMI is 34, and really remembering that over 30 absolutely puts you at risk for prolapse. So with this, I'm going to say that I would pull her back and see if we can kind of talk about other types of exercises that she can be doing that potentially aren't so high impact. Even if she gets out and walks with the baby and a stroller, and kind of get some movement in that way, and then specific targeted exercises based on our findings from our musculoskeletal exam, and reassure her that we can hopefully grade her back into running when we can meet some of those goals. So this one, from a risk-benefit analysis, I would say we're going to hold off and hopefully pull her back a little bit. And finally, to wrap up, why is this important? This was actually a paragraph that was in the article that I based all of this on, and I actually want to read it because I think it's really good. I think it really sums everything. So, in keeping with sports medicine rehab, perinatal services need to be proactive rather than reactive. So let's stop assuming that childbirth is a natural process only requiring natural recovery. Women experience significant physical and psychological changes during pregnancy and childbirth. The principles of rehab encourage us to optimize recovery in any situation where function and well-being is compromised. So if a sports person experiences trauma, rehabilitation needs are evaluated to optimize their recovery. Let's honor women with the same values, principles, and standards of care, and ensure that equitable services are available across all populations. So that is my why. That is why I am passionate about this. That's why I want to get the word out. I hope you all can spread the word that really we are available as physical therapists to really wear many hats and kind of, be the eyes, ears, and hands of a health team that can really support these patients in returning to hopefully healthy activity, healthy running, and kind of promote well-being with all of our patients. So on that, I'd like to finish up and see if there are any questions out there. I think we have a few minutes left.
Feel free to unmute yourself or type it to the chat. All right, while they're doing that, I have a question.
Yeah.
So runners tend to enjoy running, and they do not like it when you tell them not to run.
Mhm.
And usually, in my experiences, if you tell a runner not to run, they look at you, smile, nod, and then go run anyway. How do you manage a patient that needs to run in that way?
I am very objective. So I will actually explain my findings to them as to the potential negatives and the potential positives, just like I kind of did in the summary there, because there are typically both. So there are benefits in one hand, and I'm a runner myself. So I get it. Like I understand the drive and the desire to run. But I think if you spend enough time with a patient and you can really kind of explain the potential negatives, not just in the short term, but potentially in the long term, that can drive it home a little bit. What we often find is that with, unfortunately, a lot of these particular patients who may run after they've given birth and maybe potentially a little bit early, we will often see that when they're in their 50s, their 60s, they're going to have urinary incontinence. They're going to have lumbar instability. They potentially may have some knee pain given some instability problems. So I will talk about the lifelong effects that not rehabilitating yourself well now can potentially have later in life. And this is just like, in my mind, like a woman with a patient with recurrent ankle sprains, right? If she doesn't 100% rehabilitate herself after that very first sprain, is likely going to happen again and again. And then she's going to have issues with the knees and, things like that. So I think if you can really kind of take a little time, might take you 5 minutes to go over that, but that can be really, really helpful in honing why. And, I'm honest with them. I'm like, I'm so sorry. This stinks. I know you want to run, but I hope you recognize that, this can really be a negative impact. And if you want to run when you're 50, you probably need to pull back a little bit right now. So whether that works or not, it varies. But I think we can do our best. That's all we can do. Present the information and be understanding, and hopefully that does the trick. So yeah, but you're absolutely right. Runners are hard. Runners are challenging. They're often not going to listen to you. So I think if you can really give them the objective why, that could potentially help them.
Excellent. Thank you.
Mm-hmm.
What other questions do you guys have? All right. Well, thank you very much for that excellent presentation. If anybody does have any questions, please feel free to contact Lauren Garges. And thank you guys very much. Please make sure you complete both the quiz and the course evaluation so that you can get credit for this course. Thank you very much.
Thank you.